All right. Well, thanks for joining us, everyone. I'm Dr. Berens. I'm the owner of Vida Family Medicine, and I'm really excited to have Dr. Nguyen here with us today. Harrison Nguyen is a double board certified dermatologist and Mohs micrographic surgeon and clinical researcher in Houston, Texas. He is the managing director at Harrison Dermatology and Research Group, the clinical assistant professor of dermatology and health economics at the University of Houston College of Medicine, and a clinical assistant professor of dermatology at Baylor College of Medicine. And so he's going to be talking with us today about a really interesting topic that I think does not get enough face time for doctors or for patients, and a lot of people are not aware of it. So I'm really excited to have you here. So we're going to be talking about hidradenitis suppurativa, which hopefully I pronounced correctly. So thanks for joining us, Dr. Nguyen.
Thanks for having me on, Dr. Berens.
Yeah, I really appreciate it. Just want to kind of have you introduce for us, what is hidradenitis suppurativa and what causes it?
Yeah, absolutely. So hidradenitis suppurativa, also known as HS, is a chronic autoinflammatory condition. And so I use those terms very, very strategically because we want patients to understand different aspects of the disease when we characterize it. So chronic meaning that we don't have a cure for it and it tends to persist over time. Autoinflammatory meaning that there's inflammation that is going on from within that leads to the main symptoms of HS. And the main symptoms of HS are patients present with tender, painful, often draining spots, specifically in the armpits, in the groin, and in the skin folds. So oftentimes underneath the breasts. And so the how it works is, or what leads to it is, it starts with occlusion of the hair follicle. So hair follicle lying in the skin, it's typically gives rise to the hair. It gives there's sweat glands, different adnexal structures that sit in the hair follicle, and there's occlusion of the follicle that then leads to inflammation from within the patient's body. Now, one of the challenges of HS is that it goes misdiagnosed for years. It's often misdiagnosed as a cyst or as an abscess in these locations, and patients will often undergo multiple incision and drainage procedures without very much relief. And so it has a tremendous impact on quality of life, and you can imagine having spots that are painful, that drain in sensitive areas, and how impactful it can be. I think it's the most impactful thing that we treat in dermatology, and part of why I'm really passionate about educating, researching it, and treating HS in our patients.
Thanks so much for sharing that. So yeah, it sounds like something that is really easy to be misdiagnosed, and often like patients might be embarrassed to bring it up because of the locations where it's being affected. So super important to be aware of that for both patients and doctors. So what are some early signs that a patient might notice to kind of trigger them to maybe go get some care about this condition?
So at its earliest phase, it presents, or it manifests as having maybe just a painful bump, again, in these areas. So again, underneath the armpits, underneath the breasts, or in the groin. And patients may attribute it to an ingrown hair or a cyst developing. But what we know is that if you have had a quote unquote cyst or a bump in more than two or more in one of these areas within a period of 6 months, there's over a 90% chance that you have hidradenitis. So again, if you have a painful bump or a bump in general in one of these areas, armpits, groin, or the or underneath the breast, if you had 2 or more in a 6-month period, there's over a 90% chance that you have hidradenitis. And so it often presents as a small painful spot that can then progress. Sometimes it drains, it becomes more painful, and then over time these bumps can lead to tunneling. underneath the skin. And so in advanced stages, patients will develop tunnels that drain and are painful, and they look like scars in these areas.
Got it. Okay. So that's really interesting. I actually didn't realize it was over a 90%
Yeah.
likelihood. Because I mean, this is something that in primary care we see all the time. And, you know, I think I have tried to be very vigilant for this condition because I remember caring for several patients who had it in residency and seeing the severity of how it can develop. So whenever I start noticing it, I always think about that I did not realize that 90% statistic. So that is like very important for me to be aware of. I'll definitely be keeping that in mind.
But Dr. Berens, even the fact that you're even aware of that, that's so amazing, right? We've done a lot, we're trying to do more and more education to, you know, other clinicians about HS. And so really we're hoping that it really just, whenever you see a painful spot in these areas, it just should maybe lead to an alarm bell. Is this HS, right? And so for years, the average delay in diagnosis from the first time a patient had a symptom to receiving a hidradenitis diagnosis was over 10 years, right? And so now we are averaging around 7 years. So it's getting better. It's moving into the right direction, but it's still far from where we need to be. And something that you and listeners may find interesting is that the first FDA-approved medication for HS came out in 2016. It was Humira, and Humira was manufactured by a company called AbbVie. Now, when AbbVie first introduced Humira for HS, they actually got it approved through the orphan drug pathway. And so to have the orphan drug pathway, you have to have fewer than 300,000 people affected by the condition in the United States. And what we've known since just 2016 through now, 2025, just in 9 years, the prevalence is actually is estimated to be greater than 1% of the population. So as you think about 1% of, let's say, 300 million in the United States, we're looking at 3 million or more patients that have HS in the U.S. So far from the 300,000 or fewer that we thought affected patients in 2016.
That's so interesting. And I mean, I guess it's one of those things where it's like, if you don't have a treatment for it, you kind of like, why would you maybe go through the formal process of diagnosing if you don't have something to offer the person? Maybe that's why it's like was so under recognized. But you know, I have some other thoughts about why it might be under recognized that we'll get into later. But I think it just reminds me of so many of the patients that I see. So I see a lot of patients with PCOS, and it's a similar story with PCOS. There's like a super long delay in diagnosis between when the patient first sees symptoms and when they actually get a formal diagnosis of PCOS. And when I look it up, it says the average is anywhere from like 3.5 to 4.5 years. But then there's been some studies showing up to like 25 years delay in diagnosis for PCOS. And I'm just curious, this is going a little off script, but since we're talking about this, you know, one of the things that I have always heard and observed that seems to be associated with HS is having some sort of underlying metabolic dysfunction. And I think like in the patients that I see, so often when they go to the doctor, either they don't go to the doctor because they experience, you know, weight bias or weight stigma. And so they're just don't want to go and get a lecture. Or when they go to the doctor, the focus is always on their weight. You need to lose weight. And so like any conditions that they're actually experiencing are sort of ignored or overlooked. What is your experience on that overlap and like where, like sort of mechanistically where that might be coming from?
Yeah. So we do see increased prevalence of PCOS in HS patients. And, you know, part of what I do in my initial visits is I actually don't bring up weight at all for the first couple visits, because you're right. For these patients, they have heard this narrative for a long time, especially if it's not the first time that they have heard that it's HS. They hear that, oh, you have to lose weight. And I really want to shift the attention away from this being the patient's fault and really trying to emphasize that we're working together as a team to get this better for you. And so I haven't, you know, PCOS is bringing me a lot farther back to med school. I don't remember too much about the mechanisms of PCOS, but what we know about HS is an autoinflammatory condition, right? And so we also see other autoinflammatory diseases occur in HS. And so inflammatory bowel disease also occurs at higher rates with HS, metabolic syndrome, which also has an inflammatory component. But Dr. Berens, is there an inflammatory component to PCOS that drives the disease?
Yeah, so I mean, it's the underlying thing is insulin resistance, which then leads to like elevated levels of insulin, which we know there's like this association between inflammation and having higher than normal insulin levels. So I wonder if that's like sort of the root here that is similar to these two things. But yeah, it's so interesting because there is this, like you said, I think patients often are sort of given this experience of like, oh, well, you know, you need to lose weight. This is why this happened to you. It's because you have too much weight. And it's like, well, maybe the weight is a symptom of an underlying condition that is a similar root cause to both of these things, rather than like you gained weight and caused this problem, which I think is so often the focus. And that's, I mean, that's just like sort of the internalized like fat phobia and weight bias that exists in medical training and education and research. But it's just so fascinating to hear how much those two are intertwined.
You also brought up that there's been tremendous delays in PCOS diagnoses, but it's decreased through time. Have there been some initiatives that you've been aware of that maybe we can learn from in the HS world for decreasing the time to diagnosis for HS and from the PCOS world?
Yeah, you know, I mean, I think a lot of it is awareness and education. Like, I mean, I don't know if this is true, so maybe this is just me totally speculating, but obviously like the number of females who are going through medical school and residency training has increased, and 1 in 10 women likely has PCOS. And so that ends up being a pretty substantial number of doctors who go through training and have PCOS. And so just being aware that it exists, obviously, is it important for you to consider it on your differential. You have to know about it, right? So I have to imagine that is a contributor. I don't have evidence to back that up, but I have to imagine it's a contributor. But I think also just, you know, there has been more of a push in medical education, at least since I was a med student, in really addressing implicit bias and these sort of internalized biases and stigma that we carry against, you know, for gender, race, weight, all of these things. Like I remember that was a big part of our first couple years of med school. We had those additional, you know, non-medical classes that were more about addressing patient care and bedside manner and learning the sort of people side of medicine. And so I have to imagine that has also contributed, and just in the way that we're looking at the patient, and rather than saying like, oh, you're overweight and you cause these problems, like, oh, you have this underlying condition. Weight gain is maybe a symptom of this condition. And rather than looking at you and thinking that I have this assumption about your behaviors and how you've caused these problems for yourself, I'm looking at the big picture and recognizing there may actually be something else going on that needs our help. You're struggling with something.
I love that.
Yeah.
Okay, awesome. Thank you.
Yeah. Well, thanks for taking me on that little aside, because I was just so fascinated when you were telling me that and hearing that those parallels there. So going back to our scheduled topics, if a patient has these early signs that you're talking about, these bumps, what are some things that they can do to help care for themselves to try to prevent that progression that you talked about into like the larger lesions, the tunneling, all of that? What can they do at home?
Well, I think it is important to seek the care of a clinician, talking with your primary care doctor to bring this to their attention. And like I said, if you have a painful or a spot underneath these locations, I think that's absolutely imperative to bring that to your attention to your primary care doctor. And having a low threshold to put on their radar hidradenitis and whether specialist care is warranted. Because early intervention is key to modifying the disease. And so if we intervene early, we can lower inflammation early. That prevents the progression of to the tunnels and the advanced scarring that is much more challenging to treat. And so a lot of our first line treatments, although they are antibiotics, it's not really geared towards managing an infection. So that's really important for me to explain to patients. This is, although we're using antibiotics, it's not because you have an infection. It's not because you are contagious to other people. Again, I want to really draw the emphasis away from anything that the patient can feel guilt or feel like it's their fault for. And so we do use antibiotics first line, both topical, so creams and different washes, as well as oral antibiotics. And now the antibiotics, some of the antibiotics we use, they have more of an effect at lowering inflammation in the body. So a common one that we'll use is doxycycline, right? Doxycycline has both antibiotic, but also anti-inflammatory properties. And really we're relying on the anti-inflammatory properties to help reduce the inflammation. And so, again, I think this, in terms of what you can do at home, I think the most important step is bringing this to the attention of your PCP, and making sure that you put on the radar. Not every clinician is as well versed as you are, Dr. Berens, with hidradenitis, and maybe putting that on their radar to see if this is warrants further care.
Okay, great. And then for myself as a PCP, I'll just kind of tell you like what I do when I see these. Like, I am often using topicals, and if things are not being controlled with topical treatments, and maintaining obviously proper hygiene in that area and avoiding excessive irritation to that area. For example, in the armpits, if we're shaving a lot, that's obviously irritating the area more, that sort of thing. At what point, or is it always that a dermatologist needs to get involved? At what point in that process would you get a dermatologist involved? It's like, is it based on frequency of lesions and severity? What would you say?
Yeah, in my opinion, I think a dermatologist who is well versed with treating HS, I think that is important for early evaluation. And we may come back and say, look, all we need to do right now is topicals, and you can follow with your PCP. But I think that early evaluation, it can be key to preventing progression of the disease. And so we do have some patients where very, very minimal intervention is needed. So just sometimes a topical antibiotic soap or a topical antibiotic cream that we can use, and then we can counsel patients, as you mentioned, Dr. Berens, on decreasing irritation, and it's even some things like laser hair removal can be helpful for some patients. And so, but I think a baseline evaluation can be really helpful for our patients to make sure that we don't have disease that can progress, because it can progress, and it can progress really quickly in some patients.
Yeah. Okay. That's really good to know. We have really struggled. I think, like you said, it has to be someone who's well versed in it. And I feel like that's not always the case when we refer a patient. So that's really good to know now you are here, so we can send patients your way when we have a concern. So that's great to know. And then tell us a little bit more about the treatment options. So you mentioned sort of those like first line things, and you mentioned Humira. What is sort of are those all of the options? Is there anything else that's new that's coming down? And how do you sort of make that decision between those earlier, sort of first line therapies versus getting something more significant like Humira involved?
Yeah. So in terms of first line therapies, we talked a little bit about antibiotics, topical as well as oral. There's also some other medications that there's a hormonal component of HS as well, similar to some of the hormonal components of acne, and that we can use. So things like spironolactone, metformin, a diabetes medication, can be used with some efficacy. But if the patient is still experiencing symptoms, and if there's at all any signs of tunneling and scarring, then really we should be thinking about ways to modulate the immune system to decrease inflammation. So there's currently 3 FDA-approved therapies for hidradenitis. First one was Humira, or adalimumab, which is a TNF alpha blocker. Second is Cosentyx, or also known as secukinumab. That's an IL-17A blocker. And then the third one is Bimzelx, which is also known as bimekizumab. That's an IL-17A and F blocker. Now, these are targeted therapies for different cytokines that lead to inflammation, and there are actually several other ones that are currently in development. We expect one to be available later this year, early next year. That is a JAK inhibitor, so it blocks inflammation through the JAK-STAT pathway, and there's several more that are currently in development. Now, we also sometimes use other things called off-label, right, Dr. Berens, where you don't have the official FDA approval, but we know that it can be very helpful. And so things like infliximab, that's a TNF alpha blocker that is in the form of an infusion that we can use to modulate the immune system. So that really looks at the medical therapies of HS, but HS, especially at the moderate to severe stages, needs to be treated both medically and surgically. So medically, we're slowing down inflammation, but if a patient has already developed tunneling and scarring or has areas that are just resistant, sometimes my patients will experience they'll get significant improvement, but there's one or two areas that the inflammation is still there. Those need to be treated surgically. And so surgical intervention involves either de-roofing, so we're removing the actual roof of the tunnel, or excision, so we're actually cutting out the tunnel itself. And so as we teach our residents that HS is best treated both medical and surgical components.
Got it. Okay, that's really important to know, because yeah, obviously that's something we're not able to do in the PCP office, and nor are we touching those immune modulators. But I think really important for patients to understand as well that like this is a multidisciplinary approach. It's multiple areas that need to be addressed. And it was so interesting what you said about the hormonal stuff, because with PCOS, like I said, the root issue is the insulin resistance. But then as a result of that insulin resistance at the level of the ovary, it results in generally overproduction of androgens or increased level of androgens. And so then you are getting, that acne, that hirsutism. And so spironolactone is often used in PCOS, and as is metformin. So this is helpful to know, like if I am seeing these patients that have, PCOS and this underlying metabolic issue, but they're also having these HS symptoms, this is another way that those medicines are helping them, not just to manage the acne and the insulin resistance, but we're also maybe addressing any predisposition they may have for HS, even if they haven't necessarily experienced symptoms yet. So that's very helpful for me to know.
Yeah.
Well, this is great. So anything else that we didn't talk about with treatment options for HS or self-care for patients that we want to talk about before we kind of get into how patients can help themselves with this issue?
No, I just want to emphasize that this is really a multidisciplinary approach to taking care of HS. Really, at the core is having a good relationship with the primary care provider who can help evaluate and screen for other comorbidities of HS. And we already talked about so many overlaps, but things like IBD, depression, and anxiety are also very common in patients with HS. And of course, metabolic syndrome. So having that PCB at the core, and then a dermatologist who can help with medical and sometimes, depending on dermatologist, surgical management as well. But then when certain areas are involved, sometimes we'll get other specialists involved. So we'll get gynecology involved as well, or sometimes the HS can track to the GI system, right? And so that they can develop fistulas between their GI tract and their skin. And so colorectal surgeons may be involved. And then when it's more extensive, we may have plastic surgery or general surgery involved. And so really, multidisciplinary care for these types of conditions is crucial.
Yeah, that's great to know. And yeah, I mean, that makes sense. Obviously, like these areas that are involved, you could see how it could spread or start to affect issues with the GI tract or the GYN tract as well. So this is really important to be aware of. Thanks so much for sharing this with us. So I think I just wanted to kind of review at the end here for our patients that are struggling with this, because as we talked about, this is so often a very sensitive sort of issue that people are embarrassed to bring up. Just I think because of, like we said, the locations are sensitive areas. And then also, like you said, people have this sort of shame or guilt of like, oh, this is an infection. I'm dirty. I did this to myself. I'm going to give this to someone. Like there's just a lot of fear and sort of shame around that. And so I just wanted to cover for myself, like for patients, if you are experiencing this, as Dr. Nguyen said, this is a really significantly serious issue that is much more common than it originally was understood to be. And it probably is even more common than that, right? Because there's so many people who are not yet diagnosed. And I can just say from my experience, like I see this a lot in my patients, and I am not a super high volume doctor, and I have not been around that long. So it's probably a lot more common than we think. And so if you are having these symptoms, bringing it up to your PCP and recognizing that if it's not being paid attention to, it's not being taken seriously, this is actually something that deserves to be taken seriously. It's not a minor issue that you should overlook. Get yourself another opinion, advocate for yourself. A lot of things that, as I mentioned, I see with my patients who do have, PCOS or metabolic syndrome. And if they are at a higher weight and they have an issue like this, it's so often blamed on their weight, but understanding that like this is an intrinsic, what did you call it? Autoinflammatory condition, right? This is not something that has, because you gained weight, you caused this to happen to yourself. Like you had this underlying predisposition internally. The way that your immune system is functioning is causing this to happen. And so understanding that it's not your fault and you do deserve to get some care. And if you're not getting the answers you need from the people that you are seeing, feeling confident to go and find someone who can help you. And obviously, Dr. Nguyen, now you're here in Houston for people to see if they are having this issue. So how can people find you, and where is your practice?
My practice is currently located in Missouri City, so in the South Houston suburbs. And our practice is called Harrison Dermatology. You can go to www.harrisonderm.com or give us a call. We have a very special interest in treating HS and really making the lives of our patients better. And we're building out a dedicated HS center where we'll offer comprehensive care for our patients, as well as be involved in research where we'll do trials to try to get access to innovative therapies for our patients.
That is so awesome to see that we're going to have this amazing resource here in Houston and for our patients, from throughout the Houston area. And I'm sure people will travel to you from other parts of Texas if need be. So thanks so much for joining us today, Dr. Nguyen. And for anyone who is joining us today or anyone who's watching this on the recording, we'll be sending out this recording to everyone who registered at the end here. And if you have any other questions or you want to reach myself or Dr. Nguyen, you can find us at our practices, and you're welcome to reply to your email with any questions you might have as well, and we'll get them to the right person.
Thank you so much, Dr. Nguyen. Yep.
Thanks.
Thanks.